예, 안녕하세요. 두 번째 경락경혈학회 학술 아카데미에 와주신 여러분 모두를 환영합니다. 오늘의 사회는 한의학연구원의 임영수 박사님께서 진행을 해 주실 것이고요. 예, 그래서 마지막에 질의응답은 통역도 있기 때문에 원활하게 여러분이 궁금하신 것 모두 생각을 같이 나누는 자리가 되었으면 좋겠습니다. 그러면 저는 이만 마이크를 임영수 박사님께 넘기도록 하겠습니다. 큰 박수로 환영해 주시기 바랍니다.
네, 안녕하세요. 저는 방금 소개받은 한국한의학연구원 임영수라고 합니다. 오늘 박희준 교수님께서 좋은 자리를 마련하셔가지고 최근에 브리티시 메디컬 저널에 침연구 특집이 출간이 되었습니다. 저와 연이 닿아서 그 중에서 세 분을 초청해서 그 내용들을 들어보도록 하겠습니다. 첫 번째 연자는 유킹장 교수님으로서 맥마스 대학에 계십니다. EBM 하시는 분들은 다 아시겠지만 고던 가이어트 교수님이라고 EBM의 거의 전설 이제 아버지라고 불리시는 분의 제자이시고요. 현재 맥마스 대학에서 계시고 중국 베이징 중의과학원과 노팅엄 대학교의 그레이드 센터 방문 교수 등 여러 가지 중요한 직책과 일을 하고 계십니다. 오늘 첫 번째로 발표해 주실 것은 이 포스터가 좀 잘못됐는데요. 세 번째 류 교수님께서 발표해 주실 Improving Acupuncture Research Progress Guidance and Future Direction이라는 주제로 20분간 발표해 주시겠습니다. 발표를 마치시고 나면 복경 종의대 유건평 교수님께서 또 다음 주제로 발표해 주시고 최종적으로 광저우 유니버시티의 리밍류 교수님께서 세 번째 주제를 발표하시게 되겠습니다.
Thank you so much, Manson, for inviting me. It is my honor to join all of you here and to share the presentation with you. I'm going to talk about improving acupuncture research, the progress, guidance, and future directions. So first, I wanted to disclose my conflict of interest. I don't have any financial conflict of interest. I do have a few intellectual conflict of interest. So I'm the assistant professor from the Department of Health Research Methods, Evidence and Impact in McMaster University. And I'm also assistant professor at the Grace Center at University of Nottingham, Ningbo, China, visiting professor at the Academy of Chinese Medical Science, and executive director of the Center for Evidence-Based Integrative Medicine. I do methodology consultancy for American College of Physicians, and a member of the Great Working Group. So I wanted to start today's talk by a piece of newspaper article. At the end of April, the New York Times have an article titled as Why Acupuncture is Going Mainstream in Medicine. And in that article, it talks about the progress of acupuncture research and cited a recent published collection on the British Medical Journal and cited many of the evidence published in the past decades. So this presentation today, we're going to be attempting to answer the question whether acupuncture is going mainstream in medicine. As you all know, many of the diseases are bothering the global population nowadays, such as chronic pain, allergy and immunology disorders, insomnia, headaches, migraines, and all of the costs for treating this chronic disease are skyrocketing everywhere in the world. Here is where acupuncture came into place. And many countries around the world are using acupuncture to treat these chronic disease. And based on the WHO reports, acupuncture is one of the widest used traditional medicine interventions It has been used in over 120 countries around the globe. So we have worked on a collection of articles attempting to talk about the evidence base and how to improve the evidence base at the end of February. So there are 9 articles in total addressing different type of study designs, mainly covered randomized controlled trials because that is the gold standard in all type of interventions. And we covered systematic reviews in acupuncture. We talk about clinical practice guideline because that is the most common used method to guide clinicians and patients in clinical decision making. And finally, we want to see what are the evidence of using acupuncture research to inform policy and reimbursement decisions. And this presentation is going to be a very broad view and trying to summarize some of the key messages that we draw from all these 9 publications. If you want to see more details, I would encourage you to go to the BMJ website to download the articles to read more about it. The first message draw from all of these 9 papers are there is a large body of acupuncture evidence exists. So I'm gonna go through the main type of studies. First is acupuncture clinical trials. As you can see from the graph on the left, the number of trials has increased every year. So especially starting from 2000 until 2020, there are over 1,000 randomized controlled trials in acupuncture published every year. And up to date, there are more than 10,000 trials. And for systematic reviews, also the number of reviews has increased dramatically over the years as well. And to date, there are over 2,400 systematic reviews. And what about clinical practice guidelines? So in one of the articles, we conducted a systematic survey of all the guidelines, including acupuncture interventions, and not only focused on traditional medicine, but also including conventional medicine guidelines. So in this survey, we identified there are 133 guidelines, reported 433 recommendations considered acupuncture interventions. And some of the most covered therapeutic areas are musculoskeletal and connective tissue disease, neurological disorder, women's health, oncology, and gastroenterology. And for all these acupuncture recommendations, conventional medical society contributed to 2/3 of all these recommendations, which is like largely in the entire body of evidence of the recommendations. The second key message we draw from the collection is there are a lot of methodological challenges in acupuncture research. So first come to mind is the challenges in acupuncture randomized controlled trials. I'm gonna provide a really broad summary. I'm sure, I believe Jianping will talk more in details with these challenges. So in summary, the biggest challenges we came across are, firstly, acupuncture therapy is complex. So it's a multifaceted techniques because it's not delivered as a pill. Rather, it used an acupuncturist or the clinician who delivers the intervention. So that is highly depending on the expertise of the clinician who delivers the intervention. And even more, I've seen firsthand in Korea, a lot of the acupuncture interventions are combined with like cupping therapies or like the pharmaco injection. So all of that make the trials very complicated and also is highly personalized. Sometimes the practitioner changes the intervention based on the patients. And secondly, patients' expectation play a large role in their treatment. And there are studies established on this. So it might be important to consider that in trials. And thirdly, sham acupuncture as an intervention, it poses challenges to implement in trials. At the same time, it might create specific effect. So these could be the unique challenges in acupuncture randomized control trials. And for acupuncture guidelines or guideline including acupuncture recommendations, what we found is the current guidelines and recommendations often do not provide enough details on the patient's population, the type of acupuncture, the point selection, and the way they deliver the acupuncture, and the comparators in the recommendation are not provided with enough details. So it creates a huge difficulty for practitioners trying to adopt the recommendations. And secondly, a lot of societies, when they're trying to develop the guideline, despite the evidence exists, they often do not utilize those evidence and ignore acupuncture as an intervention in their guidelines. And lastly, there are lots of barriers for implementing acupuncture recommendations, mainly due to physicians do not have a knowledge of acupuncture could actually be a good option for the patients. And sometimes the guideline or the recommendations are not user-friendly enough, do not provide enough information to be utilized. And also because of the workflow, the time, and the lack of resources, the hospital are not encouraging the doctors to use the guidelines as well. And for one of the reasons that the challenges in acupuncture recommendations is the current existing recommendations do not provide enough details on patients' preference. I wanted to provide like an example to explain this point. And this will be a real guideline developed by the Canadian Society of Obstetricians and Gynecologists. And the topic is on recurrent urinary tract infection. And they suggest to use acupuncture as an alternative prevention strategy in women with recurrent infection who are unresponsive or intolerant to antibiotic prophylaxis. So in this case, low dose antibiotics might cause antibiotics resistance, might cause a lot of side effects, as severe nausea or severe rashes, and might cause discomfort to the patients. They suggest that in the case of patients unresponsive or intolerant to antibiotic prophylaxis, in an ideal scenario, if they could have made patients' preference explicit, they could have made the application of acupuncture broader, because patients, even if they are responsive or tolerant to antibiotics, but if the patients place a higher value on avoiding the adverse event caused by the antibiotics, they may be preferring to use acupuncture treatment. So in this case, if the patient's preference was clearly described, the application of such recommendation could be broader. But in the current recommendations, those are not done enough. And for economic evaluations, the key issues we identify are because most of the time, the economic evaluations are done in company with the randomized control trials. And because there are limitations in the acupuncture randomized control trials, so they often do not measure the long-term outcomes enough. They do not consider the contextual factors. the reporting of the economic evaluation are not good enough. And the other thing is only very small number of countries produce their own economic evaluation. So that create challenges to apply a different result from, let's say, the economic evaluation from Germany to Korea, because simply the patients in Germany have different preferences than the Korean patients. The cost and healthcare system are completely different. So these are all the issues with the existing acupuncture economic evaluations. The third message we found from the collection is high quality studies and methodological guidance are needed in acupuncture research. In order to create a guidance informed by empirical evidence, we conducted a systematic survey exploring what are the factors might impact acupuncture's treatment effect. We could therefore designing better informed randomized controlled trials. So we surveyed all the randomized controlled trials on acupuncture in the past 5 years with sample size more than 100. And we identified 584 studies with 1,300 effect estimates. And one of the key findings are the risk of bias and the acupuncture technique related details were poorly reported. I want to give you a couple examples from the poorly reported risk of bias related items. What one we found is trials rarely report the blinding of outcome assessment and for missing data and trial registration. And for acupuncture related factors, clinicians' expertise are rarely reported. The needling angle, direction, the intensity of stimulation are also very rarely reported. We identify 5 factors that might impact the treatment effect. Those are the type of outcomes. We found quality of life, type of outcome associated with the biggest treatment effect, following by pain, function, non-pain type of symptoms, pain and major events. And we also find single-centered study associated with larger treatment effect compared to multi-center studies. The type of acupuncture stimulation is also a factor. We found the penetrating type of acupuncture like the manual and electric acupuncture are associated with larger effects compared to the acupressure and the ear acupuncture. And we found the frequency of treatment, the treatment session, so higher frequency is associated with larger treatment effect compared to lower frequency. And the studies reported funding, not reported funding associated with larger effects. And based on the empirical evidence I just showed you, we composed a panel of 27 international experts who conducted the highest quality randomized controlled trials in acupuncture. And also we included trialists and methodologists from other areas like surgery. And we developed a list of guidance to conduct high quality acupuncture trials. So I'm gonna briefly go through it. So the most important thing before starting a trial is to establish a rationale and a research question using systematic reviews. We found only 5% of the existing trial actually cited the systematic review and used and described the rationale. And then depending on the objective, trialists should select their patients, intervention, and the comparators, considering the acupuncturist's expertise. And if they wanted to reach the maximum treatment effect, we suggest they consider the factors we identified earlier that I mentioned. And in terms of outcome measure, we do not measure enough quality of life outcomes. So we suggest trialists incorporate quality of life measures more and use longer term follow-ups in pragmatic randomized control trials. Very rarely, current acupuncture randomized control trials measure outcomes at 6 months or longer. And finally, incorporate patients in the designing execution of the trial are rarely used as well. So we highly recommend future trialists to inform, educate, discuss, and engage with the patient's partner and organization when designing trials. So how do we improve acupuncture guidelines and recommendations? We suggest collaboration between conventional medical society with the traditional medical society, and also we encourage more collaboration across regions. Very rarely this collaboration happens. More needs to become in the future. And secondly, as we mentioned, there's a large body of evidence. The current societies are not using the existing large body of evidence enough. And then we hope that in future guidelines, the recommendations could be more patient-centric, consider patient's preference, and describe them explicitly as I mentioned in the example. And then finally, we need more implementation research, because the purpose of developing guidelines is for practitioners and patients to use them at the end of the day. And for health economic evaluations, I think it's very similar. We need more collaboration between clinicians and health economists. And then the healthcare system need to use the evidence to inform decision, although sometimes the evidence exists, but the decision makers are not using them enough. And then the economic evaluation needs to improve the reporting using checklist. And finally, as acupuncture is not like a pharmaco intervention, so more funding from the government or non-for-profit organization is needed to support more acupuncture economic evaluations. So finally, the last key message is we hope that patients, clinicians, and policymakers needs to use more acupuncture evidence for decision-making. Professor Liu will talk more on how to increase the usage of acupuncture evidence. So the key points I wanted to emphasize is we need to have a culture in the healthcare system of using acupuncture evidence to inform the decision, and probably using some of the technology and digital tools to facilitate that. And we also need to identify where the knowledge gaps are, and then to prioritize the funding to ensure the areas that are researched well enough, we don't need to put more money, but for the areas that there's a gap and needs more evidence, we will put money towards that region. Take-home message for the 20 minutes talk. First, there's a large body of acupuncture evidence exists with randomized controlled trials, systematic reviews, clinical practice guidelines and recommendations. Second, we should use more acupuncture evidence to inform clinical and policy decision-making within the healthcare system. Some of those are using evidence at the moment, but not enough. And finally, we need to engage patients more and create more patient-centric research. And we need to collaborate more within the traditional medicines community, and also across region, across country, across disciplines, So with conventional and traditional medical community. And I'm hoping the talk today will not only be on acupuncture research. We should use a similar idea and thought, try to apply that to a broader discipline. We can think about something similar to the traditional complementary and integrative medicine field. And I guess that's answer the question from the New York Times article. Probably acupuncture is going mainstream because the wide usage, the wide evidence base, and then we will be creating even more evidence in the future. And I want to thank all these collaborators from 42 institutions across 5 continents with 109 scientists that work all together on this project. Special thanks to the BMJ, and hope you could join us for the International Symposium later this year in the UK. Thank you.
Thank you very much, Madison. It was an excellent talk. 제가 초기에 좀 설명을 해드렸어야 되는데 이 BMJ 콜렉션이 나오기까지는 약 5년의 시간이 걸렸습니다. 2019년부터 시작해서 많은 시간을 걸려서 이 7편의 논문이 나왔고요. 이 메디슨 장 교수님이 주도적인 역할을 했기 때문에 처음에 연자로 초청을 했습니다. Thank you. 다음 연자는 북경중의대학교 유건평 교수님인데 발표는 Methodological Challenges in Design and Conduct of the Randomized Control Trial in Acupuncture이고요. 유 교수님께서는 장지안 스칼라라고 해서 중국의 교육부로부터 특별한 호칭 을 받으셨습니다. 현재 북경중의대학교 근거중심 중의학 연구소의 소장이시고요. International Society of Complementary Medicine Research의 지난번 몇 년 전에 회장을 하시기도 했고 노르웨이에 있는 아프캄과 호주의 웨스트 시드니 대학에서 겸임 교수로 일하고 계십니다. 그 외에 많은 발표를 하셨습니다. Jianping, are you ready to share your slide?
Okay, thank you very much, Dr. Li, for introduction. And I'm going to share the slide. Okay, firstly, I would like to thank the organizer, the Society for Meridian and Acupuncture, for inviting me to the seminar. And my topic is about methodological challenge in design and conduct of randomized controlled trial in acupuncture. As you know, acupuncture therapy is a complex intervention in traditional medicine. So what are the characteristics of the acupuncture practice? It's mainly focused on the holistic approach for the patient, for the therapeutic purposes. And secondly, the treatment principle are mainly based on the identification of symptom pattern. In acupuncture, normally is the meridian diagnosis. And typically is an individualized treatment for the patient. And also the practice are mainly based on the classical theory, the knowledge, experience, and empirical evidence of the past research. And also the outcome mainly focused on the subjective, such as symptom improvement for the patient. For acupuncture practice, actually back to 18 years ago, Professor Charlotte Patterson published an article talking about acupuncture as a complex intervention using a holistic model. So in this model, it's the effect of the acupuncture in relation to the process between the patient and acupuncturist. So it's focused on the energy, strength, and relaxation for the patient, and also the change in the personal and the societal identity. And during the process, trying to improve the symptoms of the patient. For this model, you can see that they created five different components. For example, traditionally biological support to the patient, and also psychological support, and social support, and environmental support, and also the cognitive behavior support to the patient. So in this circle, and the healthcare workers can do quite a lot, and especially establish the relationship between the practitioner and patient. And also there is a qualification requirement for the practitioners, especially. So the model of the components of the complex intervention actually applied not only to acupuncture practice, and also applied to the traditional medicine practice. And my PhD student, Dr. Yu He, has done some interview for the cancer patient who used Chinese medicine some years ago as her PhD studies. And he found that the patient have quite a lot of different understanding of the traditional system, and also different expectation, knowledge, attitude, and even different consider of the barrier when practicing the traditional medicine. And later on, we also explore the components of the complex intervention for healthcare. So we use a narrative synthesis to identify from the qualitative research from the literature. And secondly, I would like to address the challenges in the clinical practice guideline of acupuncture. So here in China, we have the China Association of Acupuncture and Moxibustion is a body to develop clinical practice guideline on acupuncture. So until now, they have published 35 clinical practice guidelines on acupuncture. And basically, there are three types of the clinical practice guidelines. Many of the guidelines are focused on the disease treatment, and some for conditions such as insomnia and pain, and also some guidelines focusing on the technical operation for acupuncture manipulation. But in reality, many of the guidelines are based on the poor quality evidence in most cases. If they use great method, normally it's based on the low or very low evidence. And also there is a wide diversity of acupuncture protocols in the different guidelines for the recommendation. The problem of the quality is existing for a long time. So Professor Tang Jin published this paper review the randomized controlled trial of traditional Chinese medicine in 1999 in BMJ. And he found out there is an obvious publication bias. This is also an acupuncture trial from 50 randomized trials. So generally, the main problem is the small sample size, the single center and open label trial using the subjective outcome and publication bias. So we noticed that a little bit improvement in this area because we have evaluated the risk of bias in acupuncture RCT published in English journal by Chinese author. It is based on my PhD student thesis. And you can see the trial quality is basically in the moderate. You can see the green color is the low risk of bias, but the yellow and the red color representing unclear and high risk of bias for the randomized trial. However, if you look at the acupuncture trial included in the Cochrane Systematic Review published in Chinese, the RCT is published in Chinese, but they were included in the Cochrane systematic review, you can see that less than 10% of the trial reported as a low quality, low risk of bias. The majority of these trials with a high risk of bias. And for the English RCTs, relatively nearly 20% of this trial with a low risk of bias. So there are still some difference between the English published paper and also the Chinese journal published papers. As if we look at the design of the effect research, we have to recognize that RCT is a golden standard to evaluate the efficacy of the interventions. So evidence base of RCTs are supported to make any recommendations for clinical practice guideline. However, the major challenge is lack of competency we find out in the research methodology, especially in our country setting, resulted in the unclear randomization, inappropriate implementation of trial, such as registration of the protocol, informed consent, and quality control of the procedures. And most of the trial use composite outcome measure, so it is very difficult to extract the individual components of the effect. And finally, sometimes is the selective reporting of the outcome, because most of the protocol are not registered or published. So we can see that this is one of the major problems. And finally, the insufficient reporting of adverse reactions in these trials. So the methodology challenge in acupuncture trials with this, we raised some questions in relation to this field. So one question is about the research question coming from the clinical practice based or the research based. This is quite different because many of the trials are based on the research interest by the researchers. And secondly, there's a differentiated between the efficacy and the effectiveness. So sometimes we are in a difficulty to differentiate what is the real purpose of the clinical trials, because the efficacy and effectiveness represent the different objective of the trial. So for example, for the component effect, we can call it an efficacy effect. But for the clinical practice effect, we normally consider as effectiveness for the overall benefit from the patient. And for the sham control, we normally try to differentiate the specific and non-specific effect. Then we will design a sham control. And of course, we, from our understanding of the complex intervention, we need to understand the patient expectation and the doctor-patient relationship and the social psychological context. And finally, in clinical practice, normally the practitioner or acupuncturist, we're trying to enhance the non-specific effect by the different ways to doing that. So for example, based on the culture and the philosophy context, and plus the practitioner's techniques for the operation. So now we will look at some of the challenges in the acupuncture studies. So the first challenger is the research question and objectives. So for my understanding, one of the evaluation is based on the practice. So based on the practice, we are trying to evaluate the complex intervention of acupuncture therapy. And we need to consider multiple components and also understand the patient expectation. And sometimes we need to observe the relationship between practitioner and patient. And we take the whole system perspective to take the therapy as a whole for the patient benefit, and using the comprehensive outcome measure, for example, the quality of life. However, if we based on the research interest-based evaluation, normally it's focused on a specific question. For example, acupuncture has a specific effect for relieving pain, something like that. And secondly, it's focused on the disease and condition, and most of the components of the impact of the effect were controlled in the randomized trial. So we normally call it randomized control trial because we try to control quite a lot of the components, and normally using the standardized procedure for the clinical trial. And finally, the outcome measure using more specific outcome measurement. A second challenge is how to develop acupuncture protocol. So I think there are three ways to develop. One is a standardized acupuncture protocol. So that means all the participants receive the same treatment across all the different intervention group. And secondly is using a semi-standardized protocol. So that means all participants receive the essential treatment, for example, the essential acupoints and plus additional therapies. So for example, you can add in some extra points and using moxa or bloodletting for some of the patient with a different pattern of symptoms. And finally, individualized protocol. So each patient received the tailored treatment based on the practitioner's diagnosis for the pattern differentiation and their own prescription. So I think these three different conditions actually exist depending on your clinical question and depending on your setting for the different acupuncture protocol. And third challenge is how to determine the acupuncture dosage. As we understand, the number of needle maybe is one of the issues. So for example, the guidance under the traditional medicine series, then you can choose the different acupoints. And second is the stimulation. In clinical practice, there is electric, and non-electric acupuncture, and also touchy sensation, and also different manipulation by the practitioner. And certainly the retention of leathering, the time of the retention of leathering, and also the treatment session and duration. And finally, the interaction. So because we understand the interaction may be enhance the benefit of the patient. So yes or no would make different. And challenge 4 is how to differentiate acupuncture specific effect from non-specific effect. So this issue is come from the debate on some of the researchers thought acupuncture is a placebo effect. So to answer that question, people trying to design the sham acupuncture. Actually, there is no real placebo acupuncture because placebo normally used for medication, but it's difficult for non-pharmaceutical interventions to making a placebo. So normally it's using a sham acupuncture and trying to answer acupoint's effect and long acupoint effect, and the penetrate or long penetrate, and acupoint specific effect, and acupuncture as a therapy specific effect. So these are the different level to trying to differentiate the different effect from the acupuncture therapy. So this is a typical description in the published paper for design the sham acupuncture. In this case, they use the 1 milliliters away from the acupoint as a location for the sham acupuncture, and also penetrate the skin but only as shallow as possible to make it prevent occurring acupuncture stimulation. So you can see and you can know that the sham acupuncture is actually not the real placebo acupuncture. Challenge 5 is the research design. We need to consider the context consideration, the different culture, different philosophy, and also the setting. And secondly, the participant, we need to consider the disease and the pattern combination. And complex intervention, if you consider the holistic approach, then double blinding is actually block your communication between doctor and patient. Individualized treatment with pattern differentiation. So we have to answer the question whether individualized treatment is better than the standardized acupuncture treatment. And also context conception in relation to the intervention. So blinding is difficult. So most of the trial using the open label, but we suggest or recommend outcome assessor blinded. But patient blinded is also difficult, especially for Asian countries. And the possible solution to methodology challenge, we think we need to clarify the efficacy or effectiveness for the acupuncture trial objective. And secondly, we can use the mixed method, embedding the qualitative method into quantitative method. And we can also consider stratification by the participant, for example, naive patient or the old patient, the high expectation versus low expectation, and strong preference and non-strong preference, etc. And also you can also consider a 3-arm trial to compare the standardized treatment and individualized treatment and versus the usual care or sham acupuncture treatment. To summarize of the factors influencing effect research, the design is one of the most important issue. And secondly is the power of the study sample and also the accuracy of the defining participant depending on the diagnostic criteria and the traditional medicine diagnosis. And also the details of acupuncture based on the stricta and also the compliance of the treatment. So for the research modality for acupuncture, we think there are different levels. So the one level is focused on the whole system level to evaluate acupuncture therapy based on the clinical practice. We actually evaluate effectiveness. And if we want to differentiate which therapy or which components have the benefit compared with the placebo or sham, you can differentiate the different components using the factorial design and evaluate the efficacy. And finally, we have to answer the question about how it works and to understand what is the mechanism for acupuncture. So here is a mixed method using the quantitative and qualitative method together. For example, to understand the patient expectation and doctor-patient relationship and others. And there is a paradigm changing from the previous explanatory RCT to the real-world pragmatic trial. So on the right side, we're trying to evaluate the practice, the complex intervention for the maximum optimum treatment for the benefit of patient. So that is a total effectiveness for the patient. And you can see that around some years ago, the US funded a project on the comparative effectiveness research because there is quite a lot of concern about the healthcare expenditures. So we need to compare the different interventions and the different possible alternatives in the real world setting. So here's the comments for raising that questions. despite the trials conducted each year around the world, there's still a surprisingly large gap between what we know and what we need to know to provide optimal care. So under this model, we're trying to answer the question about whether the new treatment works better or equal or less than the present standard care. And secondly, for which conditions, which indications, and in what kind of patient, and do the benefit overcome the risk and justify the cost? So that answer the different aspect of the healthcare decision issues in relation to efficacy, safety, and health economics. And also, we need to remember that acupuncture mostly used to relieve the patient symptoms. So the patient-centered outcome research is one of the issues that by the US Congress raised a project, established the PCORI aims to define methodological standards and a translation table to guide healthcare stakeholders toward the best method for patient-centered outcome research. So in this project, they want to develop the better method and also establish standards for the approach to align the research agenda with the questions underlying the patient and clinicians' uncertainty about what works best for whom and under what circumstances. So our recommendation for future trial is using the multiple disciplinary research team involved clinical epidemiologists in the study design, and also the multi-center large-scale pre-registered RCTs with international recognized diagnostic criteria and appropriate control and core outcome and high-quality methodology. And mixed methods are encouraged to use to understand what is the optimized, the right patient for the right treatment for the right patient. And finally, acupuncture trial should be reported according to the consort and stricta to reduce the waste of trial, because many of the trial cannot be recommended in the clinical practice guidelines. So the future direction toward acupuncture, we suggest applying evidence-based approach to establish the therapeutic effects and the safety, so that many we need to do systematic review and meta-analysis, and also to execute pragmatic studies to addressing cost effectiveness and healthcare service research, and to develop multidisciplinary model for healthcare and establish evidence base for the integrative healthcare. And finally, we actually don't like the alternative medicine because the name is not a right terminology. So one comment from the New England Journal of Medicine that they mentioned that there's only one medicine that has been adequately tested and medicine that has not. Medicine that works and medicine that may or may not work. So when the medicine has been tested adequately to be effective, and then it will be combined in the mainstream medicine, like Yuqing just mentioned in the first slide. Thank you very much for your attention. Thank you.
Thank you very much. Excellent. Your presentation. 다음 연자는 광저우대학의 리밍류 교수님인데 제목은 Evidence on Acupuncture Therapies is underused in Clinical Practice and Health Policy입니다. 유 교수님은 전공이 메디컬 통계이고요. 2020년에 월드 탑 2% 사이언티스트로 언급되셨습니다. 그리고 원래 광저우 대학에서 중의학을 전공하시고 맥마스 대학의 고등과학교 교수님 방에 계신 것 같고요. 카롤린스카 인스티튜트에서 교환 교수로 지낸 바가 있으십니다. 유 교수님을 모시고 강의를 들어보도록 하겠습니다. 리밍, can you share your slide?
Thank you, Professor Li. Thank you for your invitation. It is my great honor to attend this conference. And today, my speak topic, Today my speak topic is the evidence on acupuncture therapy is underused in clinical practice and health politics. So I remember 2 years ago, and Professor Medicine invite me to collaborate with each other to do this so meaningful job. And 2 years is a very long period, and I think each other have contribute very much work for this project. And now the project has been published in BMJ, and this is a very exciting things for us. Okay, and my research team take responsibility for 2 papers. One is published in BMJ, and another is published in BMJ Open. And this is one of our articles in the BMJ. And you know, just as Professor Madison said, and our work, it is very exciting work because another thing is that our work's results has been directly cited and reported in the Time. As you know, the Time is one of the world's very famous magazine, and this report has cited our research results. We made a effective disease of acupuncture. For example, from our research paper, we have made clear the effective disease of acupuncture by evidence. One, for example, the postural aphasia, neck, shoulder, and muscle pain, fibromyalgia pain, lactation issues after delivery, low back pain, vascular dimension symptom, and allergy symptom. We think this effective disease of acupuncture is supported by the confirmed evidence now, because different institutions and schools, they have different definition for the effective disease or the advantage disease of acupuncture. But from our work, our standard is use the grade evaluation and the EBM methodology to evaluate. Another exciting thing is that our results has also be reported in our China-made video. 人民日报新华社 just very famous in our China's media. So our works, it is also we are very great honor to do this. So and now I will introduce our work, because you know from 1975 there are more than 10,000 RCT papers of acupuncture has been published. From this huge number of evidence, we still didn't know which disease is effective disease of acupuncture by evidence, and how the evidence, what's the status of the evidence translated into the clinical practice and health politics. So this is also the question for us. And now acupuncture is widely used all over the world, but most of the diseases are focused on the pain. So from this huge number of evidence, we want to summarize the quantities and the quality of this evidence to to sort out which is the effective disease and the potential disease of acupuncture. I want to make some recommendation how to improve the acupuncture evidence into the clinical practice and application in our health politics. So our work has three things. The first thing is to evaluate the number and quality of clinical evidence on acupuncture. The second is to identify the promising and the effective disease of acupuncture. The third thing is we want to make some recommendation for the construction and the use of evidence for acupuncture. Our works need to search for the symptomatic review. Symptomatic review is the sources for make some decisions for clinical practice, formulating the guidelines recommendation. So if we want to, this is the first step. We need to know the symptomatic reviews, quality and quantity. So we search the we search the evidence of symptomatic review of acupuncture from the 1975 until now, and we find that most of these diseases are focused on musculoskeletal and connective tissue disease, also the nervous system disease. This is the two main aspects of the disease. And another job, we sort out to the effective disease and potential disease. We define the effective disease of acupuncture it has the large effect or moderate effect, size effect, and also the evidence body certainty is moderate or high. So we have to do some evaluation and then some estimate. This is the table. We summarize the different condition in different outcomes and the number of RCT, the samples, the standardized mean difference, all the related risks and the evidence certainty. So from this table, we just summarize the effective disease of acupuncture, and we think the large or moderate effect with high or moderate certainty evidence disease area should be further promoted in clinical practice. And I just give one example later to illustrate this. Another example is that some disease area of acupuncture has large effect, but with low or very low certainty evidence. So this disease area should be more research, and so when we arrange an acupuncture research, we need to think this is the potential disease area, and we need to input more resources or more funding to support this area. So, and this is the evidence mapping. We use different color, different shade to present the different disease of acupuncture. And we think the evidence-based acupuncture therapy are underused, especially for the A disease area of acupuncture. For example, the post-jaw aphasia. From the Forex plot, we can see from 2015, the standardized mean difference has reached the SMD has reached the MCID value, but this result stress that acupuncture is effective in post-jaw aphasia, But just in China, postural guideline, acupuncture is recommended for treating the postural aphasia. But from the international guideline, we didn't see any recommendation for acupuncture in treating the postural aphasia. And we think this evidence is underused in clinical practice. And for another aspect, the potential disease of acupuncture, and we have select more than 60 disease area, and this area are the potential disease. It's just that this is the providing acupuncture therapy require further investigation and research funding support. So we made some instruction to how to improve the acupuncture evidence translated into our health system. The first things when we launch our acupuncture research project, we need to make a collaboration of different partners. For example, the health products maker, the acupuncture doctor, and the evidence-based methodologies. So all of these different parts, we can sit together and to talk the important questions of acupuncture and to make a very good acupuncture design, research design, and maybe we also need to how to improve our evidence in the media, in the guideline, how to improve their dissemination. So from our research team, and we also build a collaboration with the epistemological databases, and we work together to accelerating the generation, updating, evaluation, and release of the acupuncture evidence. Because from the epistemological database, their evidence are from the English language publishment, but it is linking of the Chinese databases, and our research team will update, will input the Chinese database evidence into the epistemological to help to promote the evidence dissemination. So we need to use some modern media to disseminate the evidence. We build the evidence metric. So from this metric, you can see different SR of acupuncture. They are linked into different RCT, primary research. So from this evidence metric, we can see that which SR is the included the most of the RCT, and if some new RCT has in magic, but they didn't include it in this SR, so we will update this evidence to make the conclusion more precise. So from the collaboration with epistemological database research, our team has constructed 17.7 evidence metric. So this metric can will help the clinical doctors and policy decision maker to quickly to assess the evidence. And another important conclusion is that we have sought out the effective disease and the potential disease of acupuncture. So we also published this disease area in the BMJ Open. And now, from this effective disease, we are sure that in the future, this evidence should be incorporate it into the decision making and to translate it into the clinical practice. And for the potential disease area, it is need to input more resources, more funding, more opportunity for the research to do some better research. So our work is this is our team member, team leader from our research group, Professor Xu Nengui, Professor Tang Quanzhi, and me. We are together in the same unit. And I want to thank you very much for medicine, Professor Gordon Geyer, and epistemological databases. They have contributed much more for our project. Thank you very, very much.